For diabetic complications now, a 44-year-old man with diabetes for several years, he says, comes to you for the first time. He's been unemployed for 4 years, recently able to seek medical care through the ACA. He's taking no medications at this time, no history of cardiovascular disease, and he has classic symptoms of hyperglycemia. All right, so now without obtaining any initial laboratory test or examination, okay, which of the following therapies has an established indication to consider for primary prevention to reduce his risk of complications according to the ADA 2018 recommendations? All right, would you consider starting him right away on low-dose aspirin, ACE inhibitor, angiotensin receptor blocker, statin therapy, or fenofibrate therapy? Okay, some people like the aspirin, some people like the statins. All right, so for aspirin, all right, these are the guidelines. All right, so consider aspirin therapy, okay, as primary prevention in type 1 or type 2 who are at clear increased risk of cardiovascular disease. So that includes most men over 50 and most women over 50, all right, with at least one major risk factor, all right, family history, cardiovascular disease, hypertension, smoking, et cetera, okay, and are not at increased risk of bleeding. So you do need to get a little bit more information on this patient in this case to say whether you should put him on aspirin. Just from what you have, the bare bones information doesn't have that indication. They don't recommend aspirin, all right, if there's low risk in patients under age 50 with no other major risk factors, all right? So that's kind of the main cutoff is 50 if you don't know anything else about other risk factors for this patient. All right, clinical judgment should be reserved for, again, patients with intermediate risk, such as younger patients with multiple risk factors, okay, or to patients with no risk factors until further research is available. All right. For secondary prevention, of course, yes, we use the aspirin, and if the patient has aspirin allergy or intolerance problems, clopidogrel should be used, and dual therapy for patients who have had a recent acute coronary syndrome is appropriate. All right. As far as some of the other therapies, you know, we think about using ACEs and ARBs for nephropathy risk reduction. All right, again, first, of course, you want to optimize glucose control and blood pressure control for those patients. As far as ACEs and ARBs, though, goes, all right, it is not recommended, okay, for patients that are normotensive, okay, or if they have no evidence of microalbuminuria. You don't start it just off the bat. All right, for non-pregnant patients, and you would want to consider it, okay, if there is a microalbuminuria, okay, and hypertension. All right, the statin therapy, again, many of you attached onto that one, all right, because we do say now if patient is greater than 40, all right, and with diabetes, all right, as long as they don't have any contraindications, so, you know, things like they say checking the ALT to rule out, you know, liver problems and such. If they're over 40, then they have an indication to start moderate intensity statin, all right, even if they don't have any other risk factors, all right. And in terms of what's considered to be the moderate intensity statins here, okay, 10 to 20 of atorvastatin or 20 to 40 of simvastatin. If you need to go to higher intensity statins, of course, there too. All right. I did mention fenofibrate in there because there has been some research done to see whether that particular fibric acid derivative, primarily targeting triglycerides, would be helpful, but the Accord lipid study did not show any improvement in CVD events. Did see some actual improvement in retinopathy, but still that's not enough for us to say that patients should be put on fenofibrate just to reduce retinopathy.